The flying doctors and the paramedics of the helicopter emergency medical service have some of the most rewarding jobs in the world, but also amongst the most difficult and the most demanding. The service, HEMS for short, was set up in 1989, based here on the roof of the Royal London Hospital in Whitechapel, as a way of getting the skills and expertise of the hospital directly to the patient wherever it's needed most. When a call comes through from the London Ambulance Service, the team can be airborne within 2 minutes. Their patch is anywhere within the M25. That's the entire population of Greater London. And the service has already been called out around 6,000 times. This kind of work puts an enormous emotional strain on the crews. Almost every call-out brings life and death decisions, and doctors like Gareth Davis are only called to the worst, the most distressing of cases. All of the incidents we recorded took place over the period of about a month, but we've been back to some of the people involved to see what happened to them once the emergency was over.
Patients who've been injured start the dying process from the instant the injury happened. My job is to go in and try and prevent each stage of that dying process. It can be very rewarding to halt each stage before you even get to hospital, rather than sit in a hospital and receive something that comes through the doors that is so far down the dying process. There's very little you can do about it.
It's a chap that's supposedly been run over by a tractor. He's been removed from underneath the tractor. We're not exactly sure of his injuries.
Do you want to just leave that for now and get ready for an anaesthetic?
All right, just relax, Dan. You're doing great, son. Keep going, Dan. Right, grip your hand, Dan. All right, mate. Okay.
He really was in extremis when I got to him. His crush injury to the chest had fractured all the ribs down both sides, and quite simply the mechanics of breathing, the ribs can't move the lungs up and down to breathe, and there's a tremendous amount of pain associated with all those fractured ribs.
Can we change that for a reservoir mask?
The ribs had also gone on and lacerated the lungs underneath, and there was a lot of bleeding around the lungs and a lot of air escaping around them. So basically he was unable to breathe, he wasn't getting oxygen in, and eventually that causes death.
Right, Danny, I'm going to give you some medicine now that's going to send you off to sleep and take your pain away, all right? You'll feel it going in now. Right, could all this kit start to move over that way, and we'll put the two scoop down either side. We need a chest drain that side. Hi, it's Gareth here. We've got a male approximately 50 years of age who's been run over by a bulldozer, effectively. He has a massive crush injury to his chest with bilateral hemopneumothoraces. He's been intubated and ventilated. Doesn't appear to have any injuries that I can define at the moment, but he is hemodynamically unstable from his chest. We're going to airlift him back to you with an ETA of probably about 15... Yeah. ETA of about 15 to 20. OK. See you in a bit. Bye.
One of the fundamental philosophies of the aircraft is to get a doctor to the patient's side as soon as possible. So from the incident actually happening, you can get a doctor there in 17 minutes.
Show you're returning.
You're clear, and the wind is estimated to be southwesterly less than 10.
The patient is taken right toward the doors of the resuscitation room, and at the London we're lucky we have a helipad on the roof and a lift that goes specifically to the resus room.
We're going down in the lift now. We're going down into a room in the casualty department, all right, where we're going to check you out. Now, when we get there, there's going to be about 10 or 15 people all dressed in yellow. They're going to come round either side of you, and they're going to examine you from top to toe, all right? Now, this is basically precautionary because you've been involved in a nasty accident and we want to check you thoroughly. All right? But it's a normal thing that's going on here and I don't want you to get excessively worried about it. All right? When we got to him, he was alert and orientated, pupils equally active to light, moving all 4 limbs. He had a massive anterior flail and was very dyspneic. His abdomen is soft and hasn't distended up. His pelvis seems intact. He's been hemodynamically unstable with his systolics dropping to 40 and has had a total of 3.5 litres of fluid.
Could we, before the chest drain goes in, get the patient off the vacuum mat? So, nurse 1, can you sort out the team?
We get a tremendous response when we bring patients back to the resuscitation room, being greeted by a host of surgeons, cardiothoracic, neurosurgical, orthopaedic, anaesthetists, who will then process the patients as rapidly as possible and, if necessary, operate on them in the resuscitation room itself.
1, 2, 3, down. Okay.
Just going to cut it. Sloping a little bit. Get into wind.
We've had a call out to an RTA, a road traffic accident, where a schoolboy has been hit by a car.
Be with the patient in about 30 seconds. Did you get that in the back?
Yeah,
I heard it.
Yeah, okay, we can land pretty close. There aren't any wires, a couple of trees. There's somebody wandering across, I think. We can get pretty close. No, there's a little bit of stuff on the ground. I don't know what that is, whether it's rubbish or...
It is a very special job for the pilots. There are very few helicopter jobs that allow them to land in situations like this. And it takes a very special sort of pilot to be able to do it. They have to try and ignore the medical needs of the patient and look in the cold light of day of whether it's safe or not to land the aircraft. And they can't be pushed by a doctor in the back saying that the patient's dying. They have to make a decision to land the aircraft safely.
You'll get...
These men know what they're doing, they're going to look after him. His father's here.
We're looking after him.
Patrick, put that on those eyes. Show them what colour they are. They showed me.
Need a hand, girl?
When there are so many people on scene, someone has to take some control and orchestrate things. When the doctor is on the aircraft for a 6 or 9 month or even a year's period, he gets to a lot of crashes. And with that exposure comes experience and ability to see what has to be done next.
Just accessing his left antecubital fossa, if you would.
How old is he?
How much How old is he?
11. Saw him go up in the air, come over and fall down, so I just stopped the car and run to see what we could do to help.
Patrick? Patrick, can you hear me? Can you open your eyes? Open your eyes for me.
When you see anybody who's been injured, you have to treat them all in a very simplistic way to assess their vital signs. And the vital signs are, quite simply, whether they have a patent airway, they can breathe, whether they've got problems with that breathing, whether they've got a pulse and a good blood pressure, and whether they're conscious or not. And we assess the level of consciousness by the Glasgow Coma Score, which ranges from 3 to 15. The lower scores are associated with being unconscious, and 15 is what you or I have. When you have a head injury, you may have a Glasgow Coma Score of 6, but that can deteriorate down to 3 because the brain will swell within the skull, just like when you twist your ankle. Patrick has sustained quite a nasty head injury to the back of his head, and what I want to do is take him back in the helicopter to the Royal London Hospital. He's reasonably stable at the present time. He doesn't appear to have injured himself anywhere else, but we need to give him a thorough check over as soon as we get to hospital and do a scan of his brain. Okay? And again.
Okay, oxygen tube. You got a pro pack right behind. I'll leave it on there.